afternoon, everybody. Thank you, AIOS, for giving me this opportunity. So today my talk is on cataract and myopia. Especially I'm be dealing with high myopia. By definition, it is spherical equivalent less than -6 diopters and axial length more than 26 mm. We are more concerned about it as we know, as the first speaker said, the tsunami of myopia is growing globally, especially in East Asian population, and it adds to the economic burden as well. So many studies have found this association, and especially the nuclear cataract and posterior subcapsular cataract are the dominant types of cataract in myopia. So what is so unique and why are we talking about this kind of cataract and myopia? Firstly, it is presents early, and these younger population comes with greater expectations, with a lot of demands. There's also a lot of risk involved both intraoperatively and postoperatively. And if they had already undergone refractive surgery, then post-op prediction error is a big headache. And because of increased higher order aberration, they see cataract surgery earlier. And the biggest challenge is accurate biometric calculations, including choosing the best IOL formula. So other than nuclear cataract, we have to remember the other three major risk factors associated with high myopia or maculopathy, retinal detachment, and primary open-angle glaucoma. A quick review about how cataract happens. It's mainly because of vitreous liquefaction, whereby there is increased intraocular oxygen tension combined with antioxidant capacity reduced amount. This imbalance leading on to denaturation of proteins leading to nuclear cataract, and retinal degeneration byproduct mainly because of lipid peroxidation causing posterior subcapsular cataract, and at the same time some kind of microinflammation also happens which adds to the cataract formation. So preoperative evaluation, we should start with the nature of complaints, especially note for any sudden decrease in vision where we should think about any maculopathy involved, any previous history of refractive surgery or retinal procedures done. Detailed fundus examination is a mandatory, and if we have ultra-wide field camera, it will be very helpful. Investigation must include OCT macula, PAM to prognosticate, and of course biometry. But the biggest and the greatest challenge is giving a proper counseling to know their expectations as well as to explain the risk and complications involved. So, but however we do, the refractive outcome is always less predictable because of error in the axial length measurement because of posterior staphyloma. We can overcome to an extent by doing optical biometry, or you can use newer generation formula, mainly the Barrett's Universal 2. So Barrett's Universal 2 can be the best formula both for axial length lesser and greater than 26 mm, have a target refraction from -0.5 diopters to -1.575 diopters. Better to choose monofocal IOLs as multifocal IOLs because of the capsular bag and IOL disparity. There may be chances of decentration and decreased contrast sensitivity. And for spectacle independence, go for monovision or crossed monovision. If you have intraoperative biometry, it will be very helpful. But if they have already undergone post-refractive surgery, then we have to have a detailed evaluation of prior ablation, the higher order aberration profile, and note for any corneal irregularity, and see that if they are a candidate for post-surgery corneal laser enhancement, use a proper IOL calculation, and see for any decentered ablation or irregular in depth of the laser surgeries. Yes, challenge is again in biometry calculation. There are so many solutions offered, and the best IOL formula will be to go for Barrett's Truque no history or to use ASCRS IOL calculator. So, and again, IOL selection can be monofocal IOL, or if we have any kind of refractive surprise, if we expect any kind of surprise, then go for light adjustables or small aperture IOLs. So, intraoperatively, again, we start with topical anesthesia. As the previous speaker said, to have a antechamber fluctuation should be avoided in any cost by minimizing incision leakage and have the lower bottle height and increased flow rate. And watertight wound closure must be the endpoint. And if you are choosing SICS, be ensure to even put a suture at the end. And the well-centered moderate size rexes should be aimed for. And lens iris retropulsion syndrome is one of the characteristics of in these cataracts, where it is characterized by AC deepening, pupil dilatation, concave iris configuration, leading on to reverse pupillary block. It can be avoided by lifting the inferior iris with the Sinskey hook. So don't hesitate to use the capsular tension ring if this is doubtful zonular dehiscence or zonular weakness. And IOL must be completely covered by rexus margin, and better not to leave them aphakic and at least to put a 0 per IOL to avoid vitreous movement. And in case of any surgical changes has to be done if post-refractive eyes, like RK, avoid the RK incision or go for scleral tunnel, and better put a stabilizing suture. In post-phakic IOL, the risk of endothelial injury should always be in mind, so use a surplus amount of OVD. So coming to refractive outcomes, there is significant visual improvement in these eyes, but which is mainly due to removing the dense nuclear cataract and removing the greater prismatic effect of spectacles. But the percentage as per the Zio et al. In meta-analysis is only 63%. And the percentage decreases as axial length increases. And this poor visual outcome is mainly attributed to pre-existing myopic maculopathy, newly onset post-op complications, or post-op hyperopic drift. And this same kind of outcome is being studied in Shanghai myopia study, where they attributed the poor visual outcome, apart from those listed above, to corneal astigmatism or decrease in subfoveal choroidal thickness, or because of, again, the same, the PCR rate or the post-op complications. Post-op complications, first and foremost, we worry about is the PCR rate. As per the study, it increases with every 1 mm increase in axial length because of zonular weakness and vitreous liquefaction. But there can be negative correlation as well, because it's mainly handled by experienced surgeons, and the high myopia patients, they present early, and with advanced equipment, PCR can be avoided. The retinal detachment should be always in mind, so better to avoid any kind of complications because of movement of lens capsule or decreased stability of the vitreous body can lead to RD in any time in life. So maculopathy changes as in any other cataract because of early development of PVD or PCO because of large capsular bag and thinner IOL, but may not be directly attributed to myopia. Yes, capsular contraction syndrome is one of a significant complication because of the increased imbalance between the fibrotic changes in the capsule and the zonules. Yes, late dislocation of IOL will be a complication which you should remember. So IOP spike is another significant complication, maybe because of pre-existing POAG or because of the anatomical change, or there can be a steroid responder as well. So refractive surprise is only major thing which we are most worried about. That's why we keep stressing on counseling to make the patient happy, or go for either laser enhancement, and rarely piggyback IOL and IOL exchange, mainly for hyperopic LASIK patients. So 5 P's we should remember: complete pre-op examination, evaluate biometry data and formulas, preoperative counseling the patient very well, and be prepared for any intraoperative surprises, and plan for anisometropia between the eyes. So if we remember all these and go methodically and do the surgery meticulously, we can give a spectacle independence for any kind of high myopia, be it celebrity or any common man. So myopia is just not a refractive error. We should think beyond it, and it's very complicated. Thank you.
Thank you, Dr. Jeyalakshmi, for sharing your pearls.
May I ask a question?
Yeah.
Madam. Very nice presentation. You showed some relation between the high myopia and the cataract. That slide. Can you come back to that slide?
The studies?
Yeah.
No, the busy slide which shows a lot of...
Shanghai study?
No, the relation between the high myopia that leads to subcapital cataract later on.
Yeah, the cataractogenesis. Open. This one? So because of axial length elongation, vitreous liquefaction happens, right? So there is increased intraocular oxygen tension. There is more of reactive oxygen species is produced. So, but the antioxidant level is not able to combat this kind of increased reactive oxygen species. So because of this imbalance, there is denaturation of proteins, which is one cause for nuclear cataract, as well as there is hypermethylation of genes which encodes the alpha crystallins. So that all leads to nuclear cataract. Another proposed mechanism for posterior subcapsular cataract is the retinal degeneration byproducts. So that is because of lipid peroxidation that leads to PSCs. So plus all other microinflammations, and it is all proposed theories.
Thank you.